Well, why don't we get started with the afternoon session? This is session 2 from the VCBH annual meeting. The title for this session is The Intersections of Tobacco Use and Chronic Health Conditions. We have 3 speakers, and I'll ask each of the speakers after you speak to please sit down here for the panel, which will be the questions afterwards. Our first speaker is Dr. Katherine Menson, Assistant Professor at the Lerner College of Medicine in Pulmonary and Critical Care. She did her undergraduate at the University of New Hampshire in Durham, where she had a BS and magna cum laude in molecular, cellular, and developmental biology, and then got her DO degree in Biddeford, Maine. Her postdoctoral training, University of Vermont Medical Center, where she did both residency and fellowship, residency in internal medicine and fellowship in pulmonary and critical care medicine. Dr. Menton will be addressing us today on emerging nicotine products and pulmonary health, balancing the risks and benefits. Okay.
Thank you so much for having me. I'm acutely aware that I'm going right after lunch, so bear with me. So I received some grant support from the American Lung Association, NIH, but I don't have any relevant disclosures for this topic. So, when thinking about preparing this talk, I think universally it's been validated that healthcare professionals care about their patients quitting smoking. It's just about how far they take that effort. And so looking at a group of healthcare professionals in different variety of settings, so primary care physicians, emergency medicine physicians, psychiatrists, and then nursing, dentists, dental hygienists, pretty good about asking a patient smokes. Across the board, it's almost all above 90%. But then when we think about going through the 5 A's in advising, assessing, assisting, and arranging follow-up, it gets kind of progressively worse as we go through that algorithm. And so, understanding that it's an important feature when you're encountering a healthcare professional, but really does not seem to be a lot of evidence that people are kind of going through what they need to in order to help patients quit smoking. And then a qualitative study of 27 healthcare professionals was measured on their perceptions of smoking cessation. And actually, of those 27 professionals, 61% were actually specialists in smoking cessation. And this study kind of came together and identified this quote that I'm going to read. That compared to other patients, initiating smoking cessation for a disadvantaged patient was perceived as more difficult. It's more difficult to schedule multiple appointments, and follow-up was less consistent, and treatment adherence was perceived as lower among patients compared to patients with high socioeconomic position. So no one really disagreed that smoking cessation isn't a priority, but they did kind of state these preconceived notions that it's not a priority for patients who are socioeconomically disadvantaged. So taking into account those perceptions in the healthcare field, it's obviously the next most notable thing and relevant thing to mention is EVALI. So e-cigarette or vaping-induced associated lung injury. And we think of this as kind of like the pre-pandemic epidemic, right? In my world as a pulmonologist and as an ICU physician, this was the hot news in 2019. In the United States, there were about 2,400 patients who were admitted with EVALI. 53% of those were confirmed cases. The remaining cases were suspected as probable cases. And if you're aware, EVALI is an inflammatory response within the lungs. This is a CT scan of a person with EVALI, a 38-year-old male who had confirmed EVALI. And the idea is it's almost like a pneumonia mimicker. It made patients very sick. They would have high oxygen requirements and basically needed time and support to allow that inflammation to die down. And so this, I think, really set the stage for what we think about as pulmonologists with e-cigarettes. I think everybody in this room knows that this was really later to be confirmed to be associated with vitamin E acetate in combination with THC products. But the CDC really has a very broad definition of EVALI, which is that a patient who has inflammatory findings in their lungs and e-cigarette use within the past 90 days, and pulmonary infiltrates that can't be attributed to another respiratory disease or process. And because this was a really hot topic, people were thinking about it a lot. And my perception is that this really stuck with people, right? This was an exciting new thing. But a lot of times in ICU medicine and pulmonary medicine, we can find people who have pneumonia mimickers and never exactly identify the cause of those things. So really lacking anything more than kind of a rule out diagnosis is difficult with this disease and potentially gets people labeled with EVALI, I think potentially a little more commonly than is true. So right after all of this came out, there was a lot of perception from medical societies about putting out information about e-cigarettes to the community. And this is a pamphlet, an education pamphlet from the American Thoracic Society, which is one of the biggest pulmonary societies in the world. And when asked, are e-cigarettes safe? They say the simple answer is no. And they kind of go through the fact that there are chemicals in e-cigarettes and heavy metal particles. And then the question is asked, are they helpful in helping someone quit smoking cigarettes? And they say that people claim that they can be helpful, but research studies are conflicting. And so this was published, I think, in 2019 or 2020 and has yet to be updated since that time. But this is, if you're going on the internet and trying to find validated information, kind of what's presented to patients. However, I think some very exciting data that came out earlier this year in the New England Journal is actually looking at a very large population of patients trying to get them to quit smoking with electronic cigarettes. And so this was a study out of Switzerland in which adults who were actively smoking 5 cigarettes or more per day underwent a 12-month intervention. And the control group received cognitive behavioral therapy, motivational interviewing, and shared decision-making for nicotine replacement therapy. And were given smoking cessation medications, right? So kind of the gold standard for helping people quit smoking. It was down to tailoring the level of nicotine support based on their dependence, and they received 5 telephone calls and financial incentives. And the intervention group received all of these things plus 2 starter kits for electronic cigarettes, and patients were able to choose their concentration and their flavors. And so what the study found is that they had a 77% greater abstinence rate in the intervention arm compared to the control group, right? So almost 60% of patients quit smoking at the 6-month mark. This was accounted mostly for by use of patients quitting smoking but still using e-cigarettes. So that was about 50% of the participants in the intervention group. However, the rates of dual users were higher in the intervention group. So participants who were using e-cigarettes and tobacco cigarettes were higher, and most of them were using nicotine in their e-cigarettes. So the criticism of this intervention was that the rate of dual use was higher with the intervention. We weren't truly getting enough patients off of cigarettes completely or transitioning to nicotine e-cigarettes alone. The serious adverse events between the groups were about the same, but the intervention group did have a 19% higher risk, although overall they were smaller, less frequent. So when we look at like what's actually happening in the lungs, and I heard someone say they do rat research. So these are mouse models. Don't ask me too many questions, but the mouse model is actually a very helpful model in pulmonary disease and has a lot of overlap with the human lung. So this is kind of where studies started, was looking at what airway inflammation was happening in mice who were exposed to e-cigarettes. So I just want to acknowledge that research in this market, and I think everybody here is acutely aware of how complicated it is just based on the sheer number of chemicals and the user's ability to alter products and use the products differently, and just the generation of new products over time. But in this study, mice were exposed to 1 hour of e-cigarette vapors per day, 5 days per week for 3 to 6 months. And what they found is that there were higher levels of circulating inflammatory cytokines in the mice who were exposed to e-cigarettes. And so this was shown by the graphic model below. You'll see there was actually a 519-fold decrease in a marker called ILX, which is essentially the mouse equivalent to a cytokine or an inflammatory response called IL-8. IL-8 helps recruit a type of white blood cell called neutrophils, which is the most common response to a bacterial infection, into the lungs. So the concern is that by decreasing that recruitment of that white blood cell into the lung, potentially the mice might be more susceptible to infection. There was also a 99-fold decrease in a marker called VCAM, which actually recruits for lymphocytes and monocytes, which help fight viral infections. So now we're talking about potentially impairing bacterial and viral mechanisms, inflammatory response mechanisms. There was also a significant increase in a protein called dipeptidylpeptidase 4, which is also called CD26 in the human cell. That is basically a receptor on white blood cells that recruits inflammatory cytokines. And so when that's elevated, that's been associated with diseases such as asthma and chronic obstructive pulmonary disease, or COPD. So the idea that we're decreasing potentially inflammatory responses to illness and potentially increasing risk of inflammation associated with airway diseases that we see with tobacco cigarettes. So how this translates into human studies, and I'll just mention that these studies are very small, and that's a big limitation of this data. So 10 healthy volunteers were recruited who had never used e-cigarette products or smoked. And they actually underwent bronchoscopy. That's a procedure where you go in and you lavage fluid out of the lungs, and you're looking at the types of cells that are in the lungs. They also had blood markers drawn. And so the participants had that as their baseline measurements. And then a week later, they returned. They vaped an electronic cigarette. 7 had nicotine in it, and 3 of the participants vaped an electronic cigarette that did not have nicotine, and they underwent a bronchoscopy within 2 hours of that intervention. And what they found is that there was an increased level of endothelial microparticles. What this is a measurement that's found in the blood that basically says that the airway is being degraded and circulating into the bloodstream. The EMPs are actually seen in patients who smoke cigarettes as well. So the idea that the e-cigarette with nicotine is causing enough inflammation to degrade the lining of the lung. Interestingly, though, both groups had similar up and down regulation of transcription products within their cells. So seeing that there were actually changes just from being exposed to the e-cigarette liquid. But the nicotine group is the only one that demonstrated dysregulation of something called P53. And if you were here last year and you have a really good memory, I talked a little bit about P53 at my talk last year. P53 is kind of like a checkpoint transcriptome. So if the cell is exposed to anything that's potentially toxic and alters the DNA, P53 shuts down the cell and causes programmed cell death or apoptosis. P53 is felt to be a very important factor in the development of lung cancers. So when you're seeing that there's dysregulation of P53, the concern is that you're actually setting a patient up for precancerous cells. And again, very small group. We're comparing 7 participants to 3 participants who did not receive any nicotine in their e-cigarettes. So this was an interesting tissue model in which you can actually develop mini lungs just out of some cells in culture medium. You basically can create a 3D model of a lung without having a full lung. And what this group did was exposed basically an organoid, a mini lung, to either electronic cigarette vapors or study cigarette vapors. And they controlled for the same degree of concentration exposure. And this is a heat map. So if you follow, the top here is the exposure to the study cigarette, and either the cells got exposed to 30 puffs, 60 puffs, or 90 puffs of the cigarette. And over time, with higher concentration of exposure to nicotine, those cells expressed more inflammatory markers. The bottom part of the heat map shows inflammatory marker response to those for electronic cigarettes. And so compared to air controls, those exposed to e-cigarettes had no changes in their pro-inflammatory mediators. The beating function of the cilia, so the hair that's on the cells meant to clear mucus from the lungs, the barrier integrity, and cytotoxicity. So interestingly, on a cellular level, we're not seeing that nicotine e-cigarettes actually impair function of the lung. Now, nicotine use is associated with increasing airway resistance. So when you look at the small study of e-cigarettes users who were otherwise healthy, they were exposed to 30 puffs of their e-cigarette in 30 minutes of an e-cigarette with nicotine versus without nicotine. And there was an immediate effect on lung function seen in those who received nicotine products. So there's a number of ways that you can measure changes within the lungs and the way they function. The most basic is called spirometry, and that's basically how we measure how much air gets out of the lungs. It's a good marker for testing for asthma or COPD. And then there are some more fancy tests we can do to look for those diseases as well, something called the fractional exhaled nitric oxide, something abbreviated to FeNO, and then something called oscillometry, where we're basically looking at resistance within the deep portions of the lungs and then the more central portion of the lungs. And so those who underwent exposure to nicotine, you can see in kind of the hollow dot here, had transient increases in their resistance, their reactance, their fractional excretion of nitric oxide, and decreased forced vital capacity, meaning they couldn't blow air out as much as they could before they vaped the e-cigarette with nicotine. But you can see all of those changes returned to baseline at the 2.5-hour mark and stayed consistent after that. The short-term effects of nicotine e-cigarettes are mixed. And, you know, one thing we were talking about, like exposure and secondhand smoke exposure, I think that had come up at dinner last night. So there's concern about, okay, if you are actively vaping versus passive vaping, you know, what changes might that cause in the lung? And this study of 30 participants showed that there was actually no changes in spirometry. So again, how well you can blow air out in active or passive vaping of nicotine products. And so again, just to like reiterate, spirometry is kind of our most basic and commonly used lung function testing to look at the health of the lung. So seeing in that basic testing that we're not seeing those changes is reassuring. These findings were found in those who were actively smoking cigarettes versus those who weren't. So that was across the board. We weren't seeing that those who smoke had changes compared to those who don't smoke. And the only thing that acutely changed spirometry was actively smoking a cigarette product. So, you know, basically to the point of the fact that electronic cigarettes don't seem to have the basic impairment on that spirometry level that really kind of matters to me as a pulmonologist. And then the question is, okay, what about patients who have disease or the patient populations that we're concerned about most in terms of quitting smoking? So this study looked at 57 participants who actively smoke, and half of them had mild asthma. And so mild asthma basically means it's not something that's impairing your quality of life. You're not having exacerbations. You're relatively well controlled. And they measured the acute effects of vaping nicotine on airway resistance. And so, again, I just want to reiterate the point here that the changes appear transient. The dotted line are those who don't have asthma, and the continuous line are those who do. So obviously those with mild asthma kind of across the board have markedly elevated numbers from the get-go, and those go up when you vape an electronic cigarette with nicotine. But all of them return to baseline within a 2-hour mark. What was interesting is that that fractional excretion of oxygen or of nitric oxide that I mentioned earlier, which is a marker for asthma and is known to go down with cigarette use, went down the same in both groups and again recovered in both groups. So we know that there are transient changes that are happening and potentially a little bit more concerning in patients who have even mild asthma disease. And then the question is, what effect does this have over time? So there were a number of longitudinal studies that looked at patients with chronic obstructive pulmonary disease. So again, the late manifestations of ongoing tobacco use, and looked at them over a 3-year period of time. So these patients were taken off of or given basically advice to quit smoking, provided with e-cigarettes, and measured over a 3-year period. So there are about 44 patients, and they were compared to a control arm. Those who used e-cigarettes decreased their cigarettes from about 21 cigarettes per day down to 1.5 cigarettes a day, and that was on average, which is a remarkable change. And despite the fact that there was no change in that pulmonary function test that I mentioned, spirometry, there was a decrease in the number of exacerbations patients were having of their lung disease and the degree of their symptoms. As a pulmonologist, that's a big deal. Those are patients who are utilizing the healthcare system, getting admitted to the hospital, requiring medications to treat their exacerbations. All of that is associated with morbidity and mortality in COPD. In addition, they had improvement in their 6-minute walk distance, which is also associated with long-term mortality in patients who have COPD. So not only were we decreasing their disease burden, but we were improving their functional capacity or how much they could exercise just with converting to e-cigarettes. Now, this is the graph that goes with that over time. And again, a measurement of their exacerbations per year, which maintains significance at 3 years out. One thing to note about this study is that the first author had a number of conflicts with both pharmaceutical and electronic cigarette companies. And so getting to the original paper from New England Journal of thinking about dual users, and especially those with COPD, and we are concerned about people who continue to smoke cigarette products and use nicotine vaping products. There are 2 really large observational cohorts looking at patients with COPD and trends over time. One of those studies is called the COPD gene study, and one of them is called Spiromex. And so they looked at patients who were currently smoking and followed them over a 5-year period. And of those who were currently smoking, there was a 6 to 8 times likelihood of them trying an e-cigarette. They tended to be younger, have a greater smoking history, and have more nicotine dependence. So those who had the most addiction to nicotine were more willing to try an e-cigarette. These patients, unfortunately, also had worse health-related quality of life. And again, so that's how their disease is impacting kind of their daily functioning, and worsening dyspnea scores, so the degree of shortness of breath that they had. Interestingly, though, they had less emphysema, which is it's a permanent finding of smoking changes. So once emphysema develops, there's nothing you can do, and it can be quite catastrophic once it's present. Of those who were using e-cigarettes, 47%, almost half, thought that the e-cigarettes had allowed them to cut back on how many combustible cigarettes they were using. And unfortunately, that data was being tracked and found that they were actually smoking on average 2 more cigarettes per day. So again, I think the outcome from this is that when left to their own devices and not really being provided with appropriate nicotine reduction and smoking cessation treatment, patients actually end up potentially using more nicotine products. And that was evidenced by the fact that they had higher nicotine metabolites and progression of their COPD in those dual users. So this is where the use of e-cigarettes could go wrong if not used under the right model. So interestingly, I've talked a lot about the difference between the nicotine e-cigarette products and those that don't have nicotine. And so nicotine-free e-cigarettes don't significantly alter the levels of the fractional excretion of nitric oxide that I talked about, right? So those inflammatory markers compared to those at baseline. So the concern would be that if you expose people who smoke to nicotine electronic cigarettes, potentially that could worsen this level of FeNO or the suppression that we see in that lung function marker. But when you look at patients who don't smoke, and this is baseline data in clear, and then black is being exposed to a traditional cigarette. So if you take a person who doesn't smoke and expose them to a combustible cigarette, that number does go down. But when you expose them to an electronic cigarette, there's no change. And so bringing in the component of a nicotine-free e-cigarette really doesn't alter the FeNO in those who smoke, and also doesn't change compared to baseline in those who don't smoke. This really highlights the point that those changes that we see in FeNO in patients who smoke are probably more of a long-term effect than an acute effect. And I think this also raises the question of, as we are potentially implementing e-cigarettes for patients to facilitate quitting smoking, is there a potential benefit to nicotine concentration reduction over time? So thinking about areas for future research, as I mentioned in the beginning, these studies are small, and there's suggestion that nicotine within e-cigarettes can cause airway inflammation. But, oncogene signaling or signaling of potential cancer cells are seen even with nicotine-free vaping. And so it does appear to acutely worsen lung function, but what does that mean in the long term, right? So if we're seeing these observational studies in which patients who have already developed sequelae of smoking-related disease potentially improve things that really matter in their disease process, what does that say more than anything? And I think the big question that will be on a lot of pulmonologists' mind is, what does this do for cancer risk? And of course, we just need more time to understand that. But until we really understand kind of the risk of malignancy with vaping nicotine, that'll kind of be the piece that's the big unknown from a healthcare perspective. So thank you very much.
Yeah, thank you, Dr. Menson. We'll do questions at the end as part of the panel discussion. Our next speaker in session 2 is Dr. Kelly Peck. Dr. Peck is an assistant professor in the Department of Psychiatry and Psychological Sciences at the University of Vermont. He did his undergraduate training at the University of Memphis, where he got a BA in psychology and graduated magna cum laude. Master's and PhD at the University of Mississippi in Oxford, in clinical psychology, and then came to Burlington to do his postdoc in behavioral economics and behavioral pharmacology. Dr. Peck's topic for this afternoon is nicotine tobacco use among people with PTSD. Dr. Peck.
All right. Again, I'm Dr. Kelly Peck. I'm an assistant professor here at the University of Vermont and part of the Vermont Center on Behavior and Health. Today, I'll be talking about nicotine and tobacco use among people with post-traumatic stress disorder. I've been doing research here at VCBH for a couple of years, both on the development of novel treatments for opioid use disorder, as well as a separate line of research evaluating behavioral treatments for PTSD among people with opioid use disorder. So I have no relevant disclosures to this talk. So my objectives today are to walk through and examine the prevalence as well as the factors associated with cigarette smoking in individuals with PTSD. I'll quickly summarize some theoretical explanations for the association between smoking and PTSD, talk a little bit about moderators and potential mediating mechanisms underlying this association between these two conditions, and then present an overview of treatment approaches and outcomes. So we'll start off with good news. So the prevalence of smoking in the general population has steadily decreased over the past decade. These figures come from this Meza et al. 2023 paper, and with the exception of maybe people who are 65 and older, you see this steady decrease in smoking prevalence over the past 10 or 12 years. Unfortunately, you see that individuals with mental health conditions consistently report higher rates of smoking compared to the general population. And so you can see this data from 2008 to 2017. The blue line there at the bottom is individuals with no mental health conditions. The red line is those with any sort of mental health condition. And then the green line is those with serious mental health conditions. And so consistently higher rates of smoking for those with mental health conditions. And then this data is from the most recent National Survey on Drug Use in Health. This is from 2023. And you can see that rates of tobacco use and nicotine vaping are significantly higher among individuals with mental health conditions compared to those without. So as I prefaced, one mental health condition that I'm particularly interested in is post-traumatic stress disorder, or PTSD. And so for those who are unfamiliar, PTSD is a mental health condition that occurs in people who have experienced or witnessed a traumatic event. So that could be a natural disaster, some sort of assault. Trauma looks a lot of different ways. In addition to trauma exposure, PTSD is characterized by intrusive thoughts. So thoughts, trauma-related thoughts and nightmares. A key symptom of PTSD is avoidance of thoughts, emotions, people, places, situations that has come to be associated with the trauma. You see negative alterations in cognitions and mood, and then changes in arousal and reactivity. So that could be hypervigilance, increased startle response, problems with sleep. And before I launch into my overview of the data, there were two really great meta-analyses and lit reviews on this topic, one from Kearns et al. In 2018, and then one from Irene Perico-Valverde and Diane Galema, who were here at UVM. Both of those published in 2018. Really great looks at this literature, and so I'm sort of standing on their shoulders today. So the reviews of the tobacco use and PTSD literature indicate that the two conditions co-occur at high rates. So when you think about national estimates, that about 12% of adults smoke daily, you compare that to about 30 to 40% of adults with PTSD who smoke daily. So thus you can sort of infer that adults with PTSD might be twice as likely to smoke compared to individuals without. In addition to being more likely to smoke, adults with PTSD are more dependent on nicotine than those without a mental health condition. So nicotine dependence, as measured by, say, the Fagerstrom test for nicotine dependence, is generally higher among individuals with a PTSD diagnosis compared to those who don't have a psychiatric condition. But you don't really see a difference between people with PTSD and maybe someone with another mental health condition. So you can sort of infer that having a mental health condition potentially sets you up to be more dependent on nicotine compared to somebody who doesn't. When you look at heaviness of cigarette smoking, PTSD is generally associated with heavier smoking. So those with a diagnosis, that increases the risk of smoking more cigarettes per day. And then if you compare people with PTSD to those without, those with a PTSD diagnosis smoke more cigarettes per day and report a greater number of packs smoked lifetime. So that's sort of looking at this as like a categorical variable. So PTSD versus those without. If you look at severity of symptoms also predicts heaviness of smoking. So among individuals with PTSD, higher PTSD severity is associated with smoking more heavily. So 20 or more cigarettes per day. And what's interesting is that when you look at sort of like these sort of natural occurring events, so there's one study where they looked at smoking rates following a natural disaster. And so individuals who had PTSD were at a 14 times higher risk of increasing their smoking following a natural disaster than individuals who didn't have this diagnosis. In addition, PTSD is associated with worse nicotine withdrawal symptoms. So a diagnosis of PTSD is associated with more withdrawal symptoms following overnight abstinence and when people are attempting to quit. And again, severity of symptoms is associated with greater withdrawal symptoms. And then those with PTSD are more likely to attribute their smoking lapses to either negative affect or trauma reminders. So these PTSD symptoms could be driving difficulties with quitting smoking. Similar story with craving. A PTSD symptoms and a diagnosis are associated with more craving. Among people who smoke, those with PTSD endorse greater cravings for cigarettes compared to people who don't have that diagnosis. And then people with PTSD report greater motivation to smoke to reduce craving compared to those without. So those are some markers, both the prevalence of smoking in this population as well as markers of their use. The interesting thing is that as with anyone, quitting smoking is associated with an increased quality of life for people with PTSD. And people with PTSD actually make more quit attempts than people without PTSD. And they have some distinct reasons for wanting to quit. And there have been a couple of qualitative and quantitative studies asking people about what is your motivation to quit. And people with PTSD report a greater desire to prove their self-control, so wanting to gain some control over this, over their lives. And then being interested in these immediate positive consequences like saving money. So despite the fact that they're more likely to attempt quits, people with PTSD have a lot of trouble successfully quitting. So among individuals who smoke, those with PTSD are more likely to lapse, and they exhibit a shorter time to lapse. So this figure is from Zwolinski et al. 2008, and this figure shows 1 week lapse rates for participants who are in the early phases of a self-guided smoking quit attempt. So you've got 3 different groups. Participants included those with PTSD. The other group was those with other anxiety disorders. And then the third group who didn't have any mental health conditions. And so those with PTSD were more likely to lapse within the first week following a quit attempt than those with other anxiety disorders, as well as those without any other mental health conditions. And it's also interesting to note that about 25% of those with PTSD lapsed within the first 24 hours of their quit attempt. And so when you ask folks with PTSD about their barriers to quitting, they often talk about poor mental health, negative affect, and trauma reminders. So again, you see that the symptoms of this condition not only maybe make it more likely for people to smoke, but make it more difficult to quit. So now that I presented that data, I'll kind of step back, zoom out, and let's talk about theoretical explanations. So there's an urgent need to understand the reasons for the high prevalence of smoking in individuals with PTSD, and then to understand the barriers that limit their ability to quit smoking. And so various hypotheses have been proposed to explain the high co-occurrence of these two conditions. The most widely accepted explanation is the self-medication hypothesis. People with PTSD smoke cigarettes as a way to lessen or cope with symptoms associated with their diagnosis. There could also be a bidirectional relationship in that people with PTSD, maybe they initially smoke to alleviate their PTSD symptoms, but then as their tobacco use increases and they become more dependent, that worsens the PTSD symptoms, and then they're sort of stuck in this cycle. There could also be shared vulnerabilities. Some examples would be like genetic factors, neurobiological structures, psychological mechanisms, or even prior exposure to other to traumatic events that put people at a greater risk for both conditions. And then, as I've talked about already, many individuals with mental health conditions report heavier smoking, greater nicotine dependence, more severe withdrawal symptoms, and that could explain their continued smoking. So there's also, among individuals with PTSD, there's an inability or I guess a lessened ability to tolerate elevated levels of negative emotional states, particularly when these individuals are confronted with trauma and stress-related situations. And so that could also contribute to higher relapse rates and lower quit rates. That's some theoretical explanations. I think it's also important to look at some potential moderators and underlying mechanisms for the relationship between these two conditions. So if we think about motives and expectancies for smoking, smoking to reduce negative affect is the most consistently identified smoking motive among individuals with PTSD. People with PTSD tend to report that they smoke in response to stress or PTSD symptoms. And in these same studies, when you ask people who don't have PTSD why they smoke, they tend to talk about antecedents like situational cues, coffee, being around other people who smoke, boredom, being alone, things like that. And so you don't see that, that response to stress or negative affect as strongly as you do in people with PTSD. So there's also this stronger expectation among people with PTSD that smoking will improve their negative mood states. And so this data sort of provides some support for the self-medication model. People are smoking to cope with the psychological symptoms that they're experiencing. There's also this interesting line of research looking at anxiety sensitivity as a potential moderator or mediator of this relationship. And the idea is that anxiety sensitivity can moderate the association between PTSD and smoking. So this figure comes from Feldner et al. In 2008. And what they found was that higher levels, well, I guess first I should define what anxiety sensitivity is, but anxiety sensitivity is being fearful of anxiety and anxiety related symptoms. And so those individuals with higher levels of anxiety sensitivity and who smoked more cigarettes per day, both of those constructs were associated with higher levels of PTSD symptoms. And so the most straightforward explanation that I can find for that finding is that those with elevated PTSD symptoms who are also fearful of those symptoms, those anxiety-related responses, tend to smoke more as a way to manage their PTSD-related symptoms. There are also some sex differences. When you look at nicotine dependence as an outcome, nicotine dependence tends to be associated with more severe PTSD symptoms, particularly avoidance and hyperarousal symptoms, and that relationship may be specific to males. You don't see that same relationship in women with PTSD. And then if you look at withdrawal symptoms, the association between PTSD and smoking relapse due to withdrawal symptoms is stronger in women than men. So there are some sex differences as you look at these constructs. And then again, among people who smoke, individuals with PTSD tend to present with more severe clinical profiles. So they report more previous traumas, that's no surprise, higher negative affect, more substance use, higher incidence of other co-occurring psychiatric conditions, as well as substance use disorders. And then they report more treatment episodes related to both mental health conditions and substance use. So these are some important factors that could either mediate or moderate this relationship. So now that we have an idea of what the problem is, it's important to think about, well, what do we do with this information? How do we treat this co-occurrence? And so there really isn't a lot of research on empirical, or we don't have much in the way of empirically supported treatments for co-occurring cigarette smoking and PTSD. Only a handful of published randomized controlled trials have targeted treatments for this comorbidity. But there are a couple of observational studies that have been conducted among veterans that indicate that PTSD symptom severity predicts cigarette smoking. I showed that in a couple of these slides. The more severe your symptoms are, the stronger these markers of cigarette smoking tend to be. What they found is that patients who demonstrate clinically meaningful improvements in their PTSD symptoms are more likely to quit smoking. So there's this idea, well, like if we can treat the PTSD, if we see a reduction in these PTSD symptoms, then maybe we also see some reductions in some of these smoking behaviors. And so you can see through the literature, the idea is that, well, maybe integrated treatments are the way to go. So integrated treatments that address both the cigarette smoking and the PTSD symptoms may be the most efficacious approach for this population. So I'll walk through a couple of these RCTs that I thought were pretty interesting. So this study was from Maeck et al. In 2010. And they compared smoking cessation that was integrated with mental health care within the VA. So smoking cessation program, and then just standard mental health, being enrolled in a standard mental health care clinic in the VA. And they compared that to enrollment in standalone smoking cessation. They enrolled 943 individuals who smoked, who had military-related PTSD. That figure's a little bit small, but this figure shows that individuals who received integrated care, so both the smoking cessation and the mental health care, evidence a longer time to relapse. And they also found better 7-day point prevalence abstinence, both at 6 months and 18 months post-intervention compared to those who received standard care. PTSD symptoms improved for both groups, but there was no between group differences. And so this study was really the first RCT that I'm aware of comparing integrated care versus smoking cessation alone. And they found that integrated care may be more efficacious for veterans with PTSD who smoke than standard care offered through the VA. Oh, and I should have clicked again. This is the point prevalence rates for abstinence between the two groups. So you can see greater abstinence for those who received integrated care. So then in 2016, there's this study from Battaglia et al. So that's 2016. They evaluated a motivational interviewing-based smoking cessation program. So they integrated the smoking cessation program within a PTSD home telehealth care management program. And so they compared that to the home telehealth care management alone. So the intervention involved daily motivational interviewing that was delivered via telehealth. So they got a daily 2-minute session delivered via telehealth based on MI. So about 90 of those modules were available. And then they also got weekly motivational interviewing sessions with a nurse that was delivered over 12 weeks. So they enrolled 178 veterans who smoked, and they found favorable cessation rates in both groups, but there was no difference between the two groups in 7-day point prevalent smoking abstinence. So you actually see that the control group had slightly better abstinence rates, about 26% versus about 23% in those who received the motivational interviewing. The motivational interviewing, although it was focused on smoking, actually was associated with greater improvements in PTSD symptoms at a 9-month follow-up. Another study from 2016, this study examined an 8-session comprehensive smoking cessation program that was combined with a trauma management treatment. And they compared this integrated treatment to smoking cessation care alone. In this study, they enrolled 90 individuals who smoked, who had direct exposure to the World Trade Center disaster and who had elevated PTSD symptoms. And again, you see favorable cessation rates and improvements in PTSD symptoms for both groups. No difference between groups. Similar reduction in cigarette smoking. You see about 15% abstinent at 1 week, 20% abstinent at 6 months approximately for both groups, and both groups showed improvements in PTSD symptoms. I really like this study. So this is from Edna Foa and her group at the University of Pennsylvania. So prolonged exposure therapy is these prior trials that I've shown, they've integrated smoking cessation with mental health care, but they haven't really been first-line treatments for PTSD. Prolonged exposure therapy is like first-line PTSD treatment, one of the recommended treatments by the VA for the treatment of PTSD. And so in this study, they evaluated the efficacy of integrating prolonged exposure therapy with varenicline compared to varenicline alone. Everybody in this study also received smoking cessation counseling. So integrating like first-line treatment for PTSD with evidence-based treatment for smoking cessation. They enrolled 142 adults with nicotine dependence and PTSD, and they were randomized to, again, either prolonged exposure therapy plus varenicline or varenicline alone. Everybody got smoking cessation counseling. When you look at the group, when you make group comparisons, there were no differences in terms of smoking outcomes, but there was this moderated effect where participants with moderate to high PTSD severity at baseline who received varenicline plus prolonged exposure therapy achieved better abstinence outcomes compared to those who received varenicline alone. So those with more severe PTSD symptoms may benefit more from this combination than others. And as expected, those who received prolonged exposure therapy experienced greater reductions in their PTSD symptoms. That's what the intervention is designed to do. And so this is the last one that I'll show. This is the most recent one that I was able to find in my literature review. And this cognitive processing therapy is another evidence-based treatment for PTSD. And in this study, they combined cognitive processing therapy with smoking cessation counseling. People had access to pharmacotherapy as well in both groups. And so they combined the evidence-based PTSD treatment and smoking cessation versus smoking cessation alone. They enrolled 50 veterans with PTSD who smoked. And you see that smoking abstinence was similar across treatments at the end of treatment, or across experimental groups at the end of treatment, both at the end of treatment and at 6-month follow-up. And then CPT, so the evidence-based PTSD treatment, had larger reductions in PTSD symptoms at the end of treatment, but then those differences sort of disappear at the 6-month follow-up. So, when I look at that data, I sort of end up going, what do we make of this? So we got a couple of different studies. They all took different treatment approaches and sort of have some diverging or different outcomes. And so my takeaway is that the incorporation of smoking cessation treatment, so varenicline, NRT, incorporating these interventions into existing PTSD treatment protocols, there's evidence that this integrated approach is beneficial, particularly for veterans with PTSD who smoke. There's also evidence that varenicline can be combined with prolonged exposure therapy to improve smoking abstinence in patients who smoke who have elevated PTSD symptom severity. But there's more work that needs to be done. Like, as I pointed out, all of those studies that I showed, they're taking different treatment approaches. We don't have any replication across different populations. There is, I'd say some promising evidence, perhaps, that the integration of these two different treatment approaches is efficacious. And so I think that's something worth pursuing. And then if we zoom out from the individual level to the policy level, I think there are other approaches that we can take to address smoking in this population. So we've had data presented earlier today, reducing the nicotine content of cigarettes to a non-addictive level can result in a lower nicotine intake and lower nicotine dependence among current smokers, and may facilitate quitting smoking. And so we have several trials now that demonstrate that smoking low nicotine content cigarettes reduces smoking rates among individuals with mental health conditions, and it doesn't worsen psychiatric symptoms. There's also evidence that smoking cigarettes, regardless of nicotine content, reduces negative affect. So regardless of the nicotine content, smoking can still be helpful in reducing the negative affect that people report. And so given the difficulties that people have, or people with PTSD have with quitting smoking, harm reduction strategies are worth discussion, and maybe a more feasible approach to reducing the health burden of cigarette smoking. So switching to e-cigarettes or other less harmful nicotine products could be particularly helpful in this population who has a lot of difficulty with quitting. Technology is another area that we need to explore further. So whether that's app-based interventions, telemedicine appointments to increase access, all these approaches can be used to provide effective, lower cost, and wide-reaching integrated care to people with PTSD who smoke. My research group here at UVM, we've completed 2 randomized pilot trials that demonstrate the feasibility of telemedicine delivered evidence-based PTSD treatment for people with substance use disorders. However, more research is needed to determine how to most efficiently and effectively address smoking within this population. So there are some limitations in future directions, and then I'll be done. Few studies have assessed the use of tobacco products other than cigarettes in individuals with PTSD. I think there's a handful of studies. Most of the studies that have been published so far really focus on cigarette smoking. So we don't really understand the association between PTSD and other tobacco products. We need more longitudinal and experimental studies, particularly among diverse populations with PTSD. And so being able to replicate these findings in more diverse and contextually specific populations is important. Conducting rigorous evaluations of both mediators, moderators, and then the temporal sequencing of how these different constructs fit together is important. And then we need to look at individuals who are engaged in polysubstance use. Monosubstance use is an exception. Most people are using multiple substances. Stacy showed data earlier today showing the high prevalence of smoking in people with opioid use disorder. I've been doing research over the past 5 years among people with PTSD and opioid use, and we see high rates of smoking. She's going to be really embarrassed, but I'll shout out, if we have some data that we're presenting during our poster this afternoon, where we looked at smoking characteristics of adults with PTSD who are also receiving treatment for opioid use disorder. So I won't spoil that data. Go check out the poster this evening. And suffice it to say, we see even more, it's more pronounced than even the data that I presented today. So I'll stop. We won't be taking questions till the end, but thanks for your attention.
Great. Thank you, Dr. Peck. And I want to thank both of our panelists thus far for staying on time. It makes my job a whole lot easier for you guys to be timely and working with us. So our final speaker for today's panel is Dr. Patricia Cioe. She's an associate professor of behavioral and social sciences at Brown University and is affiliated with Brown University Center for Alcohol and Addiction Studies. She received her PhD in nursing research from the University of Massachusetts Worcester in 2012 and a postdoctoral fellowship at the Center for Alcohol and Addiction Studies at Brown University, where she cross-trained in HIV, tobacco dependence, and addiction behaviors. The title of today's talk for Dr. Cioe is Nicotine and Tobacco Use Among People with HIV.
Thank you so much. It's a pleasure to be here. And thank you to the conference committee for inviting me to talk about my work today. So I have no conflicts of interest to declare. I have received funding from both the National Cancer Institute and National Institute of Drug Abuse. So just to provide some background for those of you that are not as familiar with HIV care in the United States, cigarette smoking is more prevalent among people with HIV, with most studies reporting about 30 to 50% prevalence of smoking in this population. And that's in comparison to about 11 to 13% of general population smokers. So it's about 3 to 4 times more prevalent in this population. And smoking-related illness is now a major cause of morbidity and mortality in people with HIV, which is really remarkable because some of us are old enough to remember those days when people died of AIDS, and that doesn't happen so much anymore. But now we're starting to see that people are dying from cardiovascular disease when they're living with HIV, and they're also 5 times more likely to develop cancers. And smoking is the major risk factor related to both of these. 1/4 of all deaths among people with HIV who are stable on antiretroviral therapy is attributable to tobacco use. So this is really an important problem to address within our HIV clinics. It's been estimated that 90% of all lung cancers and 20% of all other cancers could be eliminated in people with HIV if we could eliminate smoking in this population. So it's really such a priority. As someone who's been treating people with HIV since the late 1990s, this is really remarkable to me that people with HIV who smoke lose more years due to smoking itself than HIV infection itself. So as I mentioned, people no longer die of complications of AIDS, they're dying from tobacco-related illnesses. So they lose about 13 years to smoking compared to about 3 to 5 years with HIV. We know that quitting smoking is difficult. We've heard that all day long today. And most people, although we have FDA-approved medications, most people are not able to maintain long-term abstinence. So smoking cessation rates are generally quoted at about 8% annually among all smokers. But we find that it's even more challenging for people with HIV. So they're less likely to quit than people in the general population. They have low quit rates. They often have poor adherence to smoking cessation therapy, and they have lack of sustained abstinence. So to me, it suggested that we needed some tailored interventions for this population. So about 6 years ago, we conducted a study, a qualitative study, where we did in-depth interviews with people with HIV who had currently or formerly smoked. And you can see their mean age was about 54, 1/3 were female, about half self-identified as Black and half self-identified as white. So we interviewed them in 60 to 90-minute qualitative interviews, and this has been published. And we asked them, what makes it difficult for you to quit smoking, or what made it difficult for you to quit smoking when you tried? And we have several quotes here that I'll just briefly go over. So people said, you know, stress made it difficult, dealing with the stress. Another one said, I'd want to quit tomorrow if I could. I just know I can't. Another one said, smoking just makes me relaxed. Another one said, I choose to smoke, I think. I don't really want to quit. If I wanted to quit, I probably could quit. Another said, I don't like the effects of what it's doing to me, but still I continue to do it. So that must mean I like it. I just don't want to quit. Another one said, I tried to quit a couple of times, but oh, it's really hard. It really is. My partner smokes, so that makes it even harder to quit. And finally, you have family members you're around and they smoke constantly, and all your friends, they smoke constantly. And they say, oh, here, have a cigarette. And like the whole house smokes cigarettes. So what am I going to do? So you can see that there are certain themes that are emerging. So 4 themes emerged from this data. And what we found was that people people smoke to manage their anxiety or their stress. They have difficulty quitting because there's a lack of social support for quitting. They're surrounded in their social networks by other people who smoke. They have low self-efficacy for quitting. They've tried to quit so many times and been unsuccessful that they feel like they just can't do it. And then finally, they have ambivalence. Some of them say, I just don't want to quit. I've given up so many other things in my life because of HIV, so I don't want to quit smoking. And based on these 4 themes, we developed 4 different projects to address each of these barriers. And I'm going to tell you about 2 of them today. So the first one is Project PNAV, or Peer Navigation. And the second one, which we just finished in April, and we're still analyzing data, but I wanted to share some of that with you, is Project Preload. So I'll tell you about 2 of those today, but I'm happy to answer questions about the other studies during the Q&A if you're interested in either one of those 2. So peer navigation for smoking cessation in people with HIV. This was a randomized control trial. It was an R21 funded by the National Cancer Institute, and I was thrilled to see someone else presenting on peer recovery coaches, which are very similar to peer navigators. So again, if you're not familiar with HIV care, peer navigators have been used in HIV clinics for many, many years. So it refers to the integration of peers into a multidisciplinary healthcare team with the goal of linking difficult to engage clients into some aspect of HIV medical care. So these are very, very commonly employed personnel in Ryan White funded clinics, and the Ryan White funding actually supports the efforts of the peer navigator within that clinic. The underlying principle is based on social cognitive theory and the theory of triadic influence. And really those peers draw from their own life experiences and build these impactful relationships with patients. And then they use those relationships traditionally to educate patients about HIV, to help them navigate the HIV care system, and then to retain those patients in care. Earlier in the epidemic, we had a lot of difficulty with antiretroviral adherence, and so peer navigators were very instrumental in helping patients take their medications and stay on medications and become undetectable. So our thought was, why don't we cross-train these peer navigators to provide some education about smoking cessation, but more importantly, to provide social support for quitting, really just support patients as they progress through this smoking cessation journey. And so we hypothesized that linking a peer navigator with a person with HIV who smokes could increase their motivation to quit, could promote access to Quitline and other resources, could probably improve adherence to smoking cessation treatment, increase social support for quitting, and then most importantly, I think, provide an example of mastery. Have someone who has faced similar challenges and has successfully quit smoking be partnered with patients who are having difficulty quitting. And so here are our study objectives. Our first aim was to look at the feasibility, accessibility, and initial efficacy of what we called the Peer Navigation Social Support for Smoking Cessation Program. And our second aim was to look at mechanisms thought to underlie smoking abstinence. And we focused on social support and self-efficacy. That's our protocol paper that's been published in Contemporary Clinical Trials, if anyone wants to take a look. But essentially, it was a 24-week randomized trial, and we enrolled 66 participants. So our inclusion-exclusion criteria were fairly standard. You had to be diagnosed with HIV, greater than 18 years old, be a daily smoker, smoking more than 5 cigarettes a day, and have an expired CO of greater than 5 at baseline. We excluded anyone who was already using smoking cessation pharmacotherapy. We excluded anyone who had an unstable medical or psychiatric illness, and we defined this as any hospitalization in the last 30 days. We also excluded anyone who had suicidal ideation in the past month or an attempt in the past year, and we excluded any adults who were pregnant or nursing. Here's our study design. So it's important to note that this study was developed as an in-clinic, in-person study, but we opened for enrollment the week before the COVID shutdown. So we transitioned our methods and it became a fully online study. In July of 2020, we reopened enrollment. So participants, patients were screened over the phone. If they were initially eligible, they were scheduled for a Zoom conducted baseline assessment, and then they were randomly assigned. And they were assigned to either standard care, which was a 30-minute nursing visit with smoking cessation counseling, and it was based on standard guidelines, or they were randomized to the active condition. And this included that 30-minute nurse visit as well, but the peer navigator was introduced at the beginning of that visit and was involved in the conversation throughout the 30 minutes. Following that, those in the active condition received phone calls every week from the peer navigator for 12 weeks. So there was a scheduled phone call every week for 12 weeks. But patients could also call their peer navigator to talk about issues throughout the week during business hours. At week 12, which was the end of that active intervention, we conducted brief qualitative interviews with participants in the active condition, and then we conducted follow-up assessments at week 4, 12, and 24. So with regard to the peer navigator, in order to be eligible, they had to have had a history of smoking at least 5 cigarettes a day for longer than 1 year. They had to have quit smoking and remained smoke-free for 1 to 2 years, and they had to have a carbon monoxide level lower than 5 at higher. These are their responsibilities. They were asked to maintain phone contact with their participants once a week through week 12, to make a quit day counseling call if any participants set a quit date, and then to maintain phone call and contact logs, which is consistent with peer navigation practice within an HIV clinic. They also attended all of our weekly meetings with the study team. As far as training goes, we gave the peer navigators 8 hours of didactic training, 2 sessions of 4 hours each. During these sessions, we also did role play, which they really enjoyed and got a lot out of. We provided a manual of topics to guide their weekly sessions, and you can see the topics on the right that were in their manual. Now, we didn't ask them to complete this content in any particular order and maybe not completely at all. It was really to help guide their conversations during those phone calls. But we really asked them to let the participant guide the conversation each week and talk about whatever the participant wanted to talk about during those weekly calls. We did ongoing training weekly with myself and with my co-investigator, Dr. Megan Pinkston, who was the clinical psychologist in the HIV clinic that we worked in, who managed the peer navigation program. And during those weekly meetings with both of us, the peer navigator could present cases and we could problem solve. And those were very helpful for the peer navigator. Here are our baseline characteristics. So you can see we had about 40% female participants, 37% identified as Black, and almost 1/4 identified as Hispanic. They were a mean age of about 54 years old. They had been living with HIV on average for about 22 years. They smoked about 16 cigarettes per day on average, but had been smoking for many, many years, 35 years on average. Their cigarette dependence score was 5.8. Confidence to quit was 6.2, and that's on a scale from 1 to 10. And you can see they made many, many lifetime quit attempts. So the mean was about 14.9. So multiple times participants had tried to quit smoking. Interestingly, about 62% said they were ready to quit at their baseline appointment in the next 30 days. So that's important to keep in mind when you see our quit rates. When we looked at feasibility and acceptability, it was really high. We had 91% follow-up rate through week 24. So the total number of study sessions completed out of those 5 sessions were about 4.7 and 4.8, no difference between conditions. Study completion did not differ between conditions, but treatment satisfaction did differ, favoring the active conditions. So that was a scale where we measured, and it could range from 8 to 32, and we saw in the active condition, the average was 29.1, whereas in control, it was 25.8. So higher treatment satisfaction with the active participants. And we had no study dropout or withdrawals. When we looked at the utilization of the peer navigator, this we were also pleased with. So there were 12 potential phone calls that they could keep with their peer navigator. The mean number of calls completed was 8.9 and the median was 9.5. 7 participants, or nearly 1/4, completed all 12 weekly calls, and half of the participants completed 10 weekly calls with their peer navigator. So really excellent utilization of the peer navigator time. When we looked at preliminary efficacy, this was not quite as promising as we had hoped it would be. So there were a number of quit attempts, and that didn't differ between study conditions. So we saw 16 had made a quit attempt in the active condition and 17 in the control condition. Self-reported quitting was 5 in the active condition, 3 in the control, no difference between groups here again. And then 7-day point prevalence abstinence, which was biochemically verified, was only 1 in the active condition and 2 in the control condition. These were very low, but we also had difficulty getting participants to call back and conduct a Zoom visit once they received their smoke-alyzer in the mail. So that was one of the problems with 7-day point prevalence abstinence, that there was a lot of missing data there. When we looked at the mechanisms underlying smoking abstinence, we saw a very promising increase in positive social support in the active condition, which we did not see in the control condition. So we were excited about that. We did not see any difference in self-efficacy change over time between baseline and week 12 in either condition. And that was a little bit surprising, especially based on the social support and the integration of the peer navigator. So the study has some limitations. It was a small sample. There are only approximately 30 in each group. We recruited from a single site in Providence. And I think the greatest limitation to the study, especially when we think about the efficacy, was that participants were only encouraged to set a quit date. We really let the participants guide whether or not they wanted to quit. We didn't set a target quit date within the study protocol, but we also weren't powered to see differences in efficacy. It was just a small pilot, and we mainly wanted to look at the acceptability and the feasibility of training the peer navigators. One of the other things that came up was medication wasn't provided for someone who did set a target quit date, and I know that somebody else mentioned that today. There were access issues, even though people were generally insured in the HIV clinic and in our study, they still had difficulty getting medications through their insurance. So as much as we like to think that the medications are covered by their medical insurance, there are strict limitations to how much they can receive, how often they can be prescribed annually, these medications. And so that was a significant issue, that when some participants said they were ready to quit, they could not access medication. So that was a problem. So just lessons learned, and where will we go with this work? So we learned that cross-training HIV clinic-based peer navigators is really very feasible, and it seems to be acceptable to study participants and to patients. Participants reported that the peer navigators provided social support and education that was salient. They closely identified with their peer navigator as someone who was like them, having had similar experiences to them. And we do have a qualitative paper from those week 12 interviews that will be hopefully under review soon. And we saw significant increases in positive social support in the active condition that were not also seen in the control condition. So our next step, hopefully, is to conduct a hybrid type 1 implementation study where we'll look at what is the feasibility of implementing this across HIV clinics in the United States. So the second project I wanted to tell you a little bit about is Project Preload. So this we just finished in April or May, and it's a 16-week randomized pilot clinical trial looking at the effect of preloading with nicotine patch for 3 weeks prior to a quit date in people with HIV. So we enrolled 51 participants and 49 were randomized. We set a target quit date at week 4, and we gave all participants 8 weeks of combination NRT. So they either received patch and lozenge or patch and gum, and it was their choice. And they also received 5 smoking cessation counseling sessions provided by a nurse. My co-investigators on this project were Dr. Chris Kaler at Brown and Dr. Megan Piper. So here's just some of our preliminary findings. So our first aim was to look at feasibility and acceptability of preloading in this population, and we found this really good acceptability. So participants were asked to preload for 21 days, and the mean number of days used was 19.7, with 70% of participants saying they used the patch every day for the 3-week period. We also looked at preliminary efficacy and 7-day point prevalence abstinence, and 16% of participants reported they had quit smoking by the end of the study. Unfortunately, this didn't differ by study condition. There were 4 in each condition, active condition and control. But when we looked at ECO levels, the participants in the preload condition had much lower carbon monoxide levels with a mean of 5.22. And in the control conditions, it was 10.89. So we're thinking maybe those in the preloading condition were smoking fewer cigarettes per day. So we need to take a look at our timeline follow back data to take a further look at that. When we looked at adherence, we wanted to see if those in the preloading condition actually had better adherence once they entered the treatment period, and we did find that they did. So those in the preloading condition, out of a 56-day course of treatment, had a mean number of days of 47, where they used their nicotine replacement therapy as compared to 32 days in the control condition, and that was significant. We also looked at craving over time, and we found that urge to smoke was significantly lower in the preloading condition, starting at week 2, which is when they were using the nicotine patch as preloading, and out to week 12 compared to control. We also found self-efficacy was significantly higher in the preloaded condition compared to control, starting again at week 2 and continuing out through the end of the study. So there is something going on where we see reduced craving, and we see improvements in confidence to quit once people have preloaded. This is some of our ongoing work. So we've also done some work with what we call Project Mind Up, and that was an 8-week single-arm pilot study looking at the feasibility and acceptability of an app-delivered mindfulness intervention for people with HIV who report anxiety as a barrier to cessation. And my co-investigators were Dr. Kaler and Dr. Judson Brewer. We've also just completed Project PACS, which was in-depth qualitative interviews looking at the feasibility and acceptability of psilocybin-assisted therapy in people with HIV who report difficulty quitting. And that manuscript is under review. And that's my poster, number 13, if you want to, number 3, if you'd like to come by. And then Project Shrek, which was using the standardized research electronic cigarette study in a 12-week switch study for people with HIV. My MPI in that study was Dr. Jen Tidy, and we're just starting to analyze those data as well. So I'd just like to acknowledge my co-investigators and my team, and thank you for your attention.
So again, thank you for all of our speakers for maintaining both providing clear presentations and staying on time. So thank you. So we're open for discussion. I'll ask anyone to has a question to either raise their hand, and either if you've got a good outdoor voice, it's okay to stand and speak, or otherwise come up to the microphone. And I will take the prerogative of asking the first question, and actually this is to Dr. Menson. So my takeaway from your talk was that we may be trading off short-term morbidities related to e-cigarette exposure, and we know very little about long-term exposure. I was intrigued by the microvesicle findings that you suggested, because we do know that endothelial microvesicles often are thrombin containing and may predispose to thrombosis. And I'm wondering if we have any data on e-cigarette exposure and thrombosis risk, which we know is also one of the major morbidities linked to cigarette exposure.
Yeah, that's a great question. Not that I'm aware of, and I have looked, but potential to have missed something. I think it gets to the question of whether nicotine e-cigarettes are causing the same degree of inflammation, right? So we have some markers that can tell us that it might be similar to combustible smoke. But again, over time, does it cause the same changes in specifically the endothelial lining of the vessels that might, promote thrombosis? I think my big takeaway from all of this is that there's some very basic science out there about the changes that happen. And then there's some reactionary things to things that have happened in the past, and somewhere meeting in the middle of really understanding longitudinally what electronic cigarettes with nicotine products do, somewhere in the middle. And those are great questions, right? Things that we know are associated with cigarette smoke. Do we see those with nicotine containing products?
Eli?
Yeah, I have my question is for Dr. Kelly Peck. I was interested to see some of the papers you were reviewing attributing smoking in response to negative affect among people with PTSD. I wonder what your thoughts are, or maybe there's some research on this, on the likelihood of the acute increases in smoking after prolonged exposure sessions. And, as a clinical psychologist and an expert in prolonged exposure, would you recommend PE among people who are quitting smoking simultaneously? Curious to hear your thoughts.
Yeah, I don't know the answer to your first question. I haven't come across anything where they measured smoking like immediately after a trauma therapy session. That would be interesting to know. I don't have any concerns about like the safety of doing prolonged exposure therapy among people with substance use disorders. People who are trying to quit, it seems like that could be a great opportunity, like particularly these integrated treatments. So if you're doing smoking cessation plus evidence-based treatment for PTSD seems to be maybe their most promising treatment modality. So I don't have any concerns about it. And I'm not aware of any evidence indicating that trauma treatment prompts relapse or like a worsening of substance use of any kind.
Again, Steve?
My question's for Kate, which I really enjoyed your talk, and there was a lot of information in there. And I'm curious, as pulmonologists, when you're thinking about the COPD patients, many of whom who have tried to quit and they failed and continue to smoke, and you think about things in terms of cost benefit, what are your thoughts about e-cigarettes as substitutes for people with those characteristics?
I mean, I think based on the data I showed, my goal is to help prevent lung function decline. And the data that we have shows that it doesn't necessarily change lung function, but then I start thinking about all the other parameters that matter. And I think things that come to mind are healthcare utilization and disease burden, right? So impacts on patients. But also the thing that really I'm left with more questions than answers is the lung cancer risk. Lung cancer is still the leading cause of cancer death in the US and globally. And so if there are ways that we can get people to quit smoking, I am on board. I do think that it can't, again, like we've seen, it can't just be left to the devices of the patient. Like the ownership is on myself and the medical community to make sure that patients are really getting as much opportunity to quit or reduce combustible cigarette smoke as much as possible. And so just telling people to try e-cigarettes, I don't think is the answer either. I think it needs to come in combination with all the other therapies are available, pharmacotherapy, nicotine replacement, cognitive behavioral therapies.
Okay, so very good answer.
Oh, it was a complete
experts.
tangential.
What I'm curious about though is you are faced with patients who have COPD, are continuing to smoke, which of course puts them at risk for lung cancer. Based on what you know, do you see any like benefit to trying to transition them to e-cigarettes based on what the evidence you have available?
Yeah, I do. And, you know, I think the barrier that I foresee, and whether this is correct or just my own experience, is that unfortunately, just like varenicline, patients come in, or just like nicotine replacement, patients have come in and they've tried it, or their cousin has tried it. And, you know, the response I get often is, oh, those things are terrible for you. And you got to go, well, you know, so are cigarettes, right? Like, let's start picking the thing that's going to be the least terrible for you. So
well, you get that in your medical office. I get that at family gatherings.
Yeah.
They ask me and I say, well, you know, I would look at these. Oh, they're terrible.
Yeah.
So, you know, the volley, I think, did some terrible damage. And the fact that we sorted it out after a while doesn't undo the damage.
Well, and I think the problem is we sorted it out as my colleague in my profession were distracted by another disease, right? We're distracted by COVID. So many things that came out of EVALI and really the understanding of EVALI. I mean, I think people kind of appreciate now, but it left really what resonated and left with pulmonologists and intensivists were that all vaping is terrible.
You know, one other thought for the whole panel, and I don't, it was a thought I was having, and you can react to it as you wish. But, you know, we have these silos by disorder. And I was thinking, you know, if you pick whichever population, and you probably have a lot of the other populations in your cohort. So COPD, I would guess a lot of people who have HIV infection and continuing to smoke have COPD. And Kelly's group, I would guess a lot of people with PTSD also have COPD, and some are likely, especially those in the opioid use disorder population, have HIV. So, you know, I'm not sure if we, instead of picking populations, we should be doing like those who have high cumulative risk versus intermediate or low. I'm not sure, but that's what I was sitting here thinking about. One factor that you are faced with.
Well, I was thinking about that during your talk. I was actually quite surprised that the one paper you showed where the anxiety and control outcomes were the same compared to those who had PTSD. But again, my clinical experience is that I think all of my patients who are smoking come with something, right? And they're not necessarily going to tell me as their specialist. But I wonder, Kelly, what you think or what you would tell someone in the medical profession treating patients who are smoking and trying to address those who might have PTSD or other comorbid mental health conditions. You know, sometimes I'm like, is it helpful to get into this, right? Or is it helpful to just help the patient identify that this might be reactionary to something else that they've experienced in their lives? They're much more likely to talk about being depressed or anxious, but not necessarily traumatic events.
Other comments from the panel? I have another one for Dr. Cioe, which actually relates to this, and that is, do you think that within the HIV, speaking about the comorbidities and the relationship between cigarette smoking and other factors in their lives, is there something unique about the HIV population in terms of those interactions that puts them at you know, opportunities for different kinds of interventions?
Yeah, well, I think there's a lot of factors. There are a lot of similar factors. You know, I think a large proportion of people living with HIV also have comorbid psychiatric illness. They also have comorbid medical illnesses, but I think they also have they have stigma and discrimination. They have a lot of loneliness, self-reported loneliness. So I think all of those types of societal type barriers, you know, things that have been imposed on the HIV community also are at play here. So that makes it also very difficult.
Other questions from the group? I've got another one for Dr. Peck, and that is in hearing the results that you quoted from some of the VA studies, I was surprised at the high smoking cessation rates that were identified. 25%, I think, point prevalence at 7 days, if that was the right metric. And I was wondering, is that about this unique population? Because that seems pretty high for at least non-incentive-based intervention, you know? So I wonder if you have thoughts about what's responsible for that.
That's a great question. I found myself thinking about that yesterday as I was looking over the slides. Particularly in that first study from 2010, it's not even like it wasn't even like evidence-based treatments. Like, we're going to refer you to 2 different VA clinics, one that addresses the mental health stuff in a fairly general way, and then, smoking cessation. And yet they still got better, like you said, 25% cessation rates. And that was a big sample. That's 950 people in that sample. So it was pretty good. And so I think, that I almost put in a slide at the end of the RCTs, which, like, the shrug emoji, like, it's sort of hard to what do we make of this? Because depending on the trial, the outcomes are different in subtle but important ways. And so, I mean, I come away from it thinking what sticks for me is that there does seem to be, depending on your population, depending on the treatment, a potential for an incremental effect. So if we address both, not just the smoking, but potentially the factors that underlie and maintain the smoking, you could potentially see better effects in this specific population. But I don't think we have enough data or enough trials to be able to say that that applies like across settings and across populations. So there's more work to be done, but I think that potential for addressing 2 things at once, you could potentially see better effects.
Makes sense. Other questions? Any questions of the panelists for each other? Oh, we got another one from the audience.
Hi, this is a question for Kelly, and all the talks were fantastic. So thank you for this. So I'm a clinician in our tobacco service, and I've always been really struck by the lack of treatments that really target perceptions that smoking alleviates anxiety. Because I think one of the challenges that we face is, we can try to get anxiety to go down, right? We can try to do these elaborate treatment programs, but the reality is we're not likely in all health settings to be able to do that, right? And so what I think sometimes we're faced with our patients is this dilemma of, what am I going to do when I'm feeling like, everything is falling apart? How am I going to cope? And so, I often try to respond with a very paradoxical response of say, you're right. You feel like this works. And so if we can't figure that out, you're never going to be able to quit smoking. And so I sometimes bring up the idea of, why don't you think we prescribe nicotine for anxiety? And I walk people through sort of what happens when they're smoking, they're anxious. I said, so basically what happens is you feel anxious and you leave the moment where you are. You step outside, you take a mental break. You now possibly walk out and you run into a whole bunch of other people who are smoking. So now you have social support. But last and most importantly, you are engaging in very slow, deep breathing. And that cigarette got all the credit.
Yeah.
And so I feel like sometimes there's actually some pretty simple paradigms that we can do to really challenge their perceptions that works. We don't necessarily have to do all these prolonged exposure paradigms, but sometimes for some patients will fight me for weeks on that, say, oh, hell no, that's not true. That's not true. But after a while they come back and they're like, oh, I know what you're talking about.
Right.
And so I feel like empowering people to realize, and what I say to them is I'll say, you are coping. Don't say that the cigarette is, you're the one who's coping. And so I wonder if sometimes we can take kind of more of that sort of challenging paradigm and empower patients to realize they're actually doing something more so. And because I think we sort of meet them down the path of, oh, you're right. And yeah, there's, we have to give you all these elaborate treatments. So just a comment observation.
Yeah. And I mean, I think your point too about so you are doing something to cope. And it's like that one slide that I showed about the anxiety sensitivity, I'd never really thought about that very deeply. But the idea with anxiety sensitivity is, so I feel like this internal like a symptom. So my heart rate increases or I start to sweat, and I interpret that negatively. So, that's anxiety sensitivity. If you think about like, what are the physiological responses associated with smoking? My heart rate increases, so it's like I'm smoking to reduce anxiety symptoms, but in reality, it actually increases those responses, which then you sort of in the cycle. So now my physiological responses are increased. I need to smoke more to try to reduce that. And so, right, being able to like challenge gently some of those perceptions, and then like developing new skills to cope with or take an acceptance-based approach. Like it doesn't have to be that I have to change this, but how can I cope with the symptoms that I'm experiencing? But yeah, I agree with you. It doesn't always have to be this 12 to 16 week intervention. It can happen maybe more gradually or in smaller doses.
I think it's a great point about anxiety and the link between anxiety and lighting a cigarette. And it's something that was the premise for our Mind Up study, the one for mindfulness. And what we essentially did was provided them with a new way to cope with that anxiety or stress that they were experiencing during the day, and saying, you don't need to grab a cigarette. You could actually practice mindfulness. And it was app-based. So they could go on their app and do a deep breathing exercise and see how that made them feel as compared to having a cigarette. So I think that there's something to be said there. There is this potential.
I'm curious. Oh, sorry. Can I ask real quick? Is there an objective way to measure negative effect? And has anybody ever done that? Like if we objectively showed patients that cigarette actually doesn't treat the negative effect you're trying to treat?
Yeah, I mean, there are measures of negative affect, several self-report measures. And so that would be an interesting, I mean, I don't, maybe that's an empirical question of like, do we measure negative affect and, being able to tie that to people's perceptions?
Yeah.
Hey, fantastic talk. So it's actually not about that, but my reading of the literature is that actually usually in experimental studies, negative affect does go down immediately. But then again, it's effective short term, not effective long term, like lots of things. And so yeah, just again, not an expert in that area, but Trish, I wanted to ask you a little bit about if you have info on kind of the content of those calls, because it's so interesting that people, 60% said they wanted to quit in the next 30 days. They were going to the calls, they're participating. If you have anything about like those conversations, I know you mentioned this was a group that really wanted social support, could benefit from social support. So yeah, if you just know anything about, if there's any data that you collected on what was covered, or, were they kind of working through some of this ambivalence, and maybe down the road, some of the seeds that were planted would bloom, or did the content wind up kind of veering off of the smoking cessation curriculum or suggested topics? Just any info you have on that.
Yeah, so it's a great question. We do have data that we haven't looked at yet. We have those, the notes that the peer navigator kept. So we have those clinical treatment notes that we haven't gone through yet. So maybe something will emerge there. But it was pretty interesting to us that 2/3 said they were ready to quit smoking the next 30 days. And then you have a trial where people just don't quit. So, so it's not really clear to us yet why that happened. And like I said, some of it was access issues, that they couldn't get the medication when they decided they did want to quit or were ready to make a quit attempt. But I don't think that accounts for all of it. So we need to dig a little deeper into those data and take a look.
Thank you all. Questions for Dr. Menson. I'm curious about your thoughts on tobacco treatment or counseling at point of like lung cancer screening, like shared decision making, especially since like going off of PTSD and anxiety, like they use it as a crutch, and especially like getting a cancer diagnosis, we know that like that's increasing anxiety and like other like psychiatric thoughts and feelings. And so they use that as a crutch. So I'm just curious your thoughts on that.
Yeah, actually, we were just talking about that. I think Dr. Rigotti was mentioning embedding that in lung cancer screening. But certainly, and actually one of the things about ordering lung cancer screening is that you are to document that you've discussed tobacco cessation when you're ordering the study. I think they're all opportunities for intervention, and certainly not to like rely on the fear factor, but have an honest discussion about what the risks are if you continue to smoke, and how to reduce that risk. Should it be done more often? Yes, probably. Yes. Yeah. Yes.
So it's still necessary.
Yes. So lung cancer screening you qualify for yearly, as long as you're actively smoking or within 15 years of smoking a certain number of cigarettes per year, or number of packs per day per year. Does it happen? I think is a different question. But yes, it's certainly it's a great opportunity, and if people are coming to you and are invested in their health and wanting to prevent potential complications from their smoking, it's a great opportunity to talk about even just like reducing as much as possible and using different therapies to achieve that.
One comment I want to throw out there as I sit there processing the conversation and the discussion we're having here, none of you would recommend, I'm with you, like recommend that all of us should know how to treat HIV, and all of us should know how to treat COPD. But we're saying that about smoking, and I was sitting there trying to think, well, what's driving that? And I think in part it's because in our healthcare systems, we don't have like a well-supported tobacco cessation service. And maybe that's why Nancy tried to or has created, started in 1993 or whatnot. But, but isn't that in a part what we're looking at? Because I think, if somebody came for such a service and they had very serious COPD, and then we would say, all right, we got to make a referral to you to the pulmonologist. But, I think as clinicians, you're faced with the fact that you have somebody in front of you who has HIV disease and they're smoking, it's going to worsen the disease, or at least, worsen their overall health status, but you don't have the same kind of option. Like, I'm going to get you over the tobacco specialist. So I'm just curious in your thoughts. Or Nancy's.
Yeah.
I've been a primary care provider since 1995, and I think that's the opportune place to have those types of conversations, because you see your primary care provider every single year. Unfortunately, primary care visits are 15 minutes long, and there's so many things to address within primary care. And then also, I don't think primary care providers feel like they have the training that they need in order to, they can provide brief advice to quit, but beyond that, they don't. So maybe that next step would be to have those embedded tobacco treatment clinics within the system.
Still in our way of thinking about that.
Yeah, I agree.
Yeah, and I think, one of the challenges that I think about is the majority of people who we see either in the opioid treatment world or in PTSD treatment world, we see a lot of people who smoke, but yet we're dealing with, like, when you're talking about opioid use disorder, you could die like today. We're thinking about long-term effects with smoking. And so you're sort of then faced with, okay, what do we prioritize today? And sometimes I'm a little bit embarrassed. Like, we see so many people who smoke, but yet we're not really doing anything to address it. And, one thought that's occurred to me is some of the work that Matt Carpenter has done about just making, say, NRT available. So not even like we're going to push it or we're going to have this program, whatever, but we're going to just send you out with some patches or some gum, something. So maybe if you don't get these huge whopping effects where you have like 25% of your sample quit, if you apply that at a population level, if you can get 3% to quit, like that's something. And so I've even thought about, Jill and I have had conversations about like, well, we're working with people with opioid use disorder and we're treating PTSD. Now we're going to layer another intervention on top of that, but just making it available, and then they can make their own decision. We could have conversations about that.
My take, I'll round out the panel discussion, it's just that I think if you're asking that question, then it needs to be a multidisciplinary intervention. And primary cares are amazing, but they're overworked and they are under-resourced. And when it comes to a disease that impacts so many different systems, mental health, or organ specific, I think you need to have a center where all those things can be addressed. I mean, I think everybody here is probably on board with that, but I am trying to counsel people on quitting smoking when I know what they really need is, cognitive behavioral therapy, or addressing, another stressor in their life, another comorbid disease that is occurring with their COPD or their smoking. And I don't know. I mean, that's what I got this last year. I remember the psychiatrist was up here saying the same thing. Why don't psychiatrists take ownership of, helping treat smoking cessation? It's like, well, if we can't answer the one person who should do it, it really should be a team-based intervention.
Other thoughts, comments?
Step up to that one. I think that some sort of mention of tobacco cessation and how important it is part of what all of these different kinds of treaters should bring in, but it doesn't mean that they have to deliver the treatment. Mm-hmm. And even in primary care, we've done some proactive treatments where the model that a lot of people are trying to promote now is that you deliver advice to quit as the clinician, and you provide a prescription or facilitate a prescription, and then you refer to somebody to do the behavioral counseling piece that is available. And then and a TTS trained person can do it. It doesn't need to be somebody with a doctoral degree or even a master's degree. That can help a lot of people. It isn't going to help everybody. And those people who need more than that, that's when you would want to refer to. And, I think a psychiatrist should know how to do this because do cognitive behavioral treatment. But so I think that the problem is that we don't have a system that allows us to have these set up and sustained in healthcare delivery systems currently, because it's very hard to bill for them. The way that we bill for things, as many people probably know, that to bill for tobacco treatment as a medical condition, which is the only way to get it paid for in an amount that would actually support somebody to have a service, is you have to be a nurse practitioner, a PA, or a doctor. And that is not how most of us want to spend our time. It's not the best use of our skills. And but we can't just have a TTS billing. So there need to be some changes in how we organize the system. And I can say that because we had a tobacco treatment inpatient service for 15 years that was supported by our hospital. And in 2020, with a change in leadership of the people who ran that department, and help was, you don't bring in revenue and we're not going to do this anymore. And the thought was that doctors and nurses in the hospital should be able to do this. Why do we need to pay someone else to do it?
Need to end there, but but I mean, I live this. I did introduce myself earlier, so I'm an obstetrician and deal with smoking. Steve and I have worked on smoking cessation in pregnancy along with Sarah for decades. And the idea that we can provide an effective intervention in the clinic setting is just not realistic. We do not provide, we can introduce the concept, but we cannot provide an effective intervention, even though we're sort of in a primary care setting when we're providing OB care. And we can highlight the incredible importance during the course of pregnancy of smoking cessation. Nevertheless, we don't have the tools to make an effective intervention. I want to thank first our panelists who all stayed on time and did a great job with questions, and also the audience for engagement. You guys did a great job in participating. So I want to thank you all.